Two. Sir, we are live now. Now we can start.
Okay. So good evening, everyone, and this is the last session of round one of Rising Star of BOS 2024. And we are on the spine session today. And to introduce the judges and welcome them, I'll invite Dr. Sanjay Dhar. So over to you, sir.
Thank you, Ashok. Good evening and welcome, everyone. As you all know, this is the first round of Rising Star 2024 of Bombay Orthopedic Society, an endeavor to find young leaders and allow them to go to the next level in academia of orthopedic. So today we have luminaries as judges. Dr. Vishal Peshatiwar, whom you all must be knowing, is a well-known endoscopic spine surgeon working at Coquitlam. And we have Dr. Arvind Vatkar, who is again a young surgeon doing exclusive spine. Besides, we have Dr. Bhavin Syal. And then we have all these youngsters who are brimming and uh, very well known in their own areas. And I'm sure today it will be an explosive session. Uh, and I welcome you all and request Ashok to start the proceedings.
Thank you,
As you
sir.
all know the rules, it is you have to stick to 7 minutes. Then there will be question answer 3 minutes. You will have to answer judges, and please stick to time. And all the best. Bye.
Thank you, sir. So we'll start with our first candidate, Dr. Maitreya. Please share your screen and start your presentation.
Sure, sir. Yeah, is my screen visible?
Yes, you can go ahead here.
Okay. Good evening, everyone. I would like to thank the respected and esteemed faculty of BOS to give me this opportunity. I will be presenting on efficacy of posterior lumbar interbody fusion in low-grade spondylolisthesis. So spondylolisthesis was first described by Habenaar and later on coined by Killian. The word literally means slipping of one vertebrae over the other. Patients generally come to us with symptoms of mechanical low back pain, sometimes radiating or radicular pain, also facetogenic pain exclusively on bending backwards. It is most commonly seen at L5S1 followed by L45. I have used the following journals for the reviewing of this study and the literature. So Meyerding classified spondylolisthesis into 5 grades, starting from grade 1 to 5, respectively stating grade 1 to be 1 to 25%, followed by grade 2, 26 to 50%, followed by grade 3, 51 to 75, grade 4 would be 76 to 100, and lastly grade 5, which is more than 100, also known as spondyloptosis. So in low-grade spondylolisthesis, when the slippage is less than 25%, when should be surgery indicated? Number one would be a failed conservative trial when the patient has done conservative trial with medications, a rehab, proper physiotherapy, back extension exercises, or even bracing. Number two would be patient complaints of severe pain, even with a lot of NSAIDs or any other medications. Number three would be progressive slippage. That is when the vertebra ascends on each other more and more on progressive X-ray films. And lastly, any neurological symptoms such as radiating pain, any paresthesia, tingling sensation, or numbness. The posterior lumbar interbody fusion approach was first described by Cloward, which stated a 3-column fixation with 360 degrees fusion and anterior support. Later on, Steffi and Setowski shared the load sharing concept, which involved an anterior interbody support along with pedicle screw fixation. Now, this approach allows us access to the both anterior and posterior columns with only one incision. Where all would it be indicated? Starting with levels of L5S1, followed by L45, and lastly 3-4 levels. Most commonly done in low-grade listhesis such as type 3 degenerative or type 2 ischemic. It is also done in DDD with spinal instability, any recurrent disc herniations, pseudoarthrosis, and lastly lumbar canal stenosis. The surgical technique opens off a midline conventional open incision. The spinous process and laminae are identified, whereas the erector spinal muscles are stripped. And laminectomy is always done preserving the facet joints and pars. Once the flavectomy is done, the dura is visualized, the nerve root is retracted, and access is given to the posterior annulus. Once the annulus is incised, we do a discectomy and disc end plate preparation to create a bilateral environment for fusion. Disc pace, once ready, is filled with morcellized bone graft and along with insertion of cage. Now, some surgeons prefer to use pedicle screw fixation before fusion, and some prefer after the fusion. Cages used are bullet, banana, peak, 3D printed, titanium, and carbon fiber. Now, coming to the literature review part, the number one study I would like to present is by Global Spine Journal, which shows low-grade single-level adult degenerative spondylolisthesis. They have compared PLF, posterolateral fusion, against PLIF, posterolateral lumbar interbody fusion, where it has shown that PLIF shows increased fusion rates, and the radiological union was comparatively 95% more. Coming to the Asian Spine Journal, which shows that PLIF is an excellent technique to visualize the neural structures. The next study, which is Journal of Spine Surgery, shows us that the interbody height restoration is great with proper neural decompression and adequate decompression. It maintains posterior support structures and also the potential of chances of 360-degree fusion. Another study in PubMed compares the efficacy and safety of PLIF versus modified TLIF, which shows that the results did not differ significantly. And the interbody fusion rate in PLIF was significantly higher than modified TLIF. Also, the cortical bone trajectory, as presented in the Global Spine Journal, it is a say that PLIF surgery in this approach for in PLIF surgery is safer due to minimal facet joint manipulation and preserves a lot of part of neural innervation and also paraspinal musculature. Now, to summarize, there is better visualization in this approach. The interbody height restoration preserves the discal stability. There is increased neural foraminal height while keeping the posterior structures intact. A complete 360-degree interbody fusion is achieved. Facet joints are preserved, so chances of ASD is reduced. And lumbar lordosis is restored, both sagittal and segmental, with anterior column support. There are, though, a few limitations to PLIF, which start with paraspinal muscle injuries, also excessive dura retraction, battered nerve root syndrome. That means the post-operatively, the patient will have radicular pain, paresthesias. There can be chances of epidural fibrosis. And lastly, we cannot perform this procedure in higher lumbar or thoracic lesions. These are my references. To carry home message, we would prefer PLIF over PLF because there are chances of pseudoarthrosis and inadequate interbody fusion in PLF. And TLIF may be preferred over PLIF because of unilateral approach. It can be used as MIS techniques, though TLIF has some shortcomings such as it cannot correct extensive lordosis. Thank you.
Thank you, Maitreya. I think you finished in time. Now over to judges for questions. Dr. Vishal, Arvind.
Dr. Maitreya, good presentation.
Thank you,
But
sir.
I would like to say that when you are presenting in terms of any studies, you have to first of all say what is the level of significance of those studies. Second, what were the amount of patients used? What
Right,
were
sir.
the so you can't just say the salient features in each and every study and then get out of it. Okay.
Got it.
I would
Yeah.
urge the other participants also that you have to first mention what is the level of significance. If it is level 1 significance, it is important. Okay. If it is level 5 anecdotal level of significance, then it doesn't hold much.
Got
Okay.
it, sir. Yes.
Yeah, that was
Yeah.
my comment in terms of that.
Thank you, sir. I
Dr.
really
Vishal, do
appreciate
you want to suggest anything or ask anything?
So Maitreya, this is Dr. Vishal. You said efficacy of postural PLIF in low-grade spondylolisthesis. What are you trying to send as a message through this paper? Efficacy as a procedure, as a standalone procedure, comparative procedure, because it was a very confusing message out there.
So I would like to recommend and also help other peers that PLIF is a technique where it can be used for alpha S1 over PLF specifically. And also the chances as it's a very very good technique, but it also requires a lot of trained efforts. So the advantages of PLIF also has its disadvantages that not only injury to the neural structures, but also requires a lot of mechanical skill and trained professionalism for a longer duration of time. Whereas comparatively, TLIF, it can be done in a better way by youngsters also, and it is not as difficult as PLIF would be.
Okay, then why are you talking about PLIF if you say TLIF is better?
So TLIF can be done only for MIS techniques, but while correcting any lumbar lordosis, also if we need proper 360
You
degree
mean to say
interbody.
that you can't do TLIF open?
Well, I've
No,
been
we
doing TLIF open way for a lot of patients, so that doesn't hold true, isn't
No,
it?
I'm
And I
not
have a
saying
very
that.
close friend who does MIS PLIF also. So
No, my point, sir, was to state that PLIF gives a better fusion for interbody and preserves the facet joints, reduce chances of ASD, and also it will, like give a proper
Maitreya, one
interbody
more question.
fusion.
I'm going to stop you there. If you already have achieved a fusion, how does it increase or decrease your ASD chances? Do you think ASD is defined by whether the facets are intact and left behind or without?
No, sir, it is with the intact facets left behind, of course. But
So if
ASD
you
will
do an
happen.
OLIF or an ALIF, do you not have any adjacent segment disease because you don't touch anything posteriorly?
No, sir, we can have. We can have.
I think that is one thing that has not yet been proven effectively by any of the papers. So you should be
Correct, sir.
mentioning that.
Right, sir.
Your slide presentation is quite good. Thank you.
Thank you, sir. Thank you so much, sir.
Hi, Maitreya. This is Dr. Taarini Johri.
Hello, sir. Good evening.
Yeah. So, the presentation was up to the point, giving the info regarding the field. Like everybody said, how do you judge which is better than what regarding TLIFs and other PLIFs? So, I would suggest it is any procedure, whatever you are comfortable with, which works in your hands, which so many over there, as everybody has said, you use whichever you are comfortable with, which is best for your patient's outcome, rather than to prove something to your peers or your colleagues.
I 100% agree, sir. The patient always comes first, and we should give that the priority. Right, sir. Thank you, sir, for the input. Thank you, judges.
Any questions there, sir?
Oh, pretty the same. But since you said TLIF is easier or simpler, this more less adjacent. Why not? You have not presented any studies that PLF on simple PLF, posterolateral fusion with PLIF means what advantages would PLF give biomechanically? Does it give any more advantage than a simple PLF, which is much faster, quicker procedure, preserves the facets?
Sir, the foraminal height would not be restored completely. The interbody or discal stability will not be achieved. Also, PLF has chances of pseudoarthrosis in the future. Whereas if we do a bilateral cage fusion in PLIF, that will lead to more 360-degree fusion and restoration of discal height, sir.
Okay.
Yeah.
Okay, thank you, Dr. Matre.
Thank you, sir. Thank you so much.
There is slightly change in the order. Dr. Aditya Chaubey, I'd like to invite you to go ahead and share your screen. There is just note on your mark sheets. This is Dr. Aditya presenting right now.
Good evening, everyone. I'm Dr. Aditya Chaubey. Today, I'd like to talk on the outcomes of short segment versus long segment fixation in the management of thoracolumbar burst fractures. These fractures are common spinal injuries that occur as a result of high velocity trauma and involve both the anterior and medial columns. And there are a lot of controversies that exist regarding the management of these thoracolumbar burst fractures. I would like to address one such controversy in this talk regarding whether the short segment fixation or long segment fixation is superior. Short segment fixation, as you can see, involves fixation of one level above and one level below the fractured vertebra, with the hope of preserving as many spinal motion segments as possible in order to achieve better range of motion post-operatively. However, it also comes with the concerns of being biomechanically weaker as compared to the long segment fixation, as you can see, which includes fixing two levels above and two levels below the fracture. and so it is considered to be biomechanically stronger. However, along with the long segment fixation, also concerns exist regarding the restricted mobility that may occur, especially in thoracolumbar junction fractures, where lumbar segments have to be incorporated into the construct, and also there is a concomitant increase in the risk for the adjacent segment degeneration occurring as a result of the restricted mobility. For preparing this presentation, I went through electronic databases like PubMed and Google Scholar using the following keywords and applied a filter to include studies within the last 10 years to find out the relevant literature to know more about this topic. I came across these three meta-analyses that directly address the topic under consideration of whether short segment fixation or long segment fixation is superior in the management of thoracolumbar burst fractures. I would like to present the outcomes under the following headings. Coming first to the surgical time and blood loss. As you can see from the forest plots, all three meta-analyses found that the short segment fixation group had a significantly shorter operative time. However, there was no difference between the between the two groups in terms of intraoperative blood loss. The clinical outcomes can be briefly described under the following three headings. Firstly, the postoperative pain. The meta-analysis that I have mentioned did not address the early post-operative VAS scores between the two groups. So this is one prospective trial that I found that found lower VAS scores in the short segment fixation group in the early post-op period, probably as a result of the lesser extensive soft tissue dissection that is required. However, at 1 year of follow-up, the VAS scores were comparable between the two groups. There was no statistically significant difference in terms of functional outcomes and in terms of neurological recovery in either of the meta-analysis that I have read. Coming to the radiological outcomes, they were assessed based on the kyphotic deformity correction that could be achieved and the loss of correction that occurred in the follow-up period, including the loss of anterior vertebral body height. Two of the meta-analysis showed favorable results for the long segment fixation group with a lesser loss of kyphotic correction in the follow-up period, indicating a more stable construct. However, one meta-analysis out of those three did not replicate these findings. The two meta-analyses that had favorable radiological outcomes also showed a greater risk of implant failure for the short segment fixation group. However, there was no difference between the two groups with respect to other complications like surgical site infections or nerve root or dural injuries. The cost effectiveness of the two modalities was also assessed by these two recent prospective studies, which found that the short segment fixation had a lesser cost to the patient owing to the lesser implant cost and also a shorter hospital stay. Now that we have understood that the short segment fixation has a shorter operative time and lesser cost to the patient, but it is plagued by the problem of a higher rate of implant failure, we need to understand the factors that are contributing to it that were explained in this review. So there are some unstable fracture patterns that involve posterior ligamentous complex disruption or a local kyphosis of more than 20 degree or a loss of more than 50% of the anterior vertebral body height. Also, other factors like osteoporotic vertebra or a stiff ankylosed spine may contribute to increased biomechanical forces on the construct leading to implant failure. Some strategies that can be used to reduce this implant failure include firstly augmentation of the posterior short segment construct by the use of index screws that I will come to in the subsequent slides, or by using a posterolateral fusion, or by increasing the support for the anterior column to reduce the kyphotic collapse, either by bone grafting through the transpedicular route or by anterior column reconstruction through an anterior approach, which itself is associated with significant amount of procedural morbidity. Going through literature, I found that there was evidence in literature that posterolateral fusion or bone grafting through the transpedicular route does not really work. One of the underlying mechanisms that they proposed was that the bone graft most likely gets resolved before it can get incorporated into the fractured vertebra. Index screws are basically pedicle screws that are inserted into the fractured vertebrae in order to augment the strength of the short segment fixation construct, at the same time trying to preserve as many motion segments as possible. But for the index screws also, they are called as intermediate screws. To work, the pedicles of the fractured vertebra need to be intact. This is another meta-analysis that gives strong evidence that the combined screw fixation technique where an intermediate screw was used led to better fracture reduction, lesser loss of correction in the follow-up period, and lower implant failure rate. Also, there was another study that talked about whether or bilateral index screws had any difference in outcomes, and found that unilateral index screw fixation also had a similar clinical and radiological outcomes when used to augment the short segment fixation. I found some limitations in literature. Firstly, there was a high degree of heterogeneity present among the studies in terms of the methodology that was used, making it difficult to compare the study and perform the meta-analysis. Also, there was absence of standardization in the surgical techniques, and there is lack of well-designed, adequately powered RCTs to further get to know the intricacies of this problem. Some lacunae in literature that I feel must be paid attention to while moving forward is whether there is a role of anterior column reconstruction in order to augment the short segment fixation. Also, if there is a role of cement augmented screws to strengthen the short segment fixation constructs, and whether there is a difference in outcomes when we consider use of the MIS approach for fixation rather than open approach that was used for all these cases. The take-home points that I want to emphasize is that the strong evidence present today states that both fixation methods lead to similar functional outcomes with a greater risk of implant failure and loss of reduction following short segment fixation. One must put index screws wherever it is possible when using short segment fixation to reduce rates of implant failure. And the choice of fixation has to be individualized based on the patient profile, if the patient is osteoporotic, or and based on the fracture patterns, identifying the unstable fracture types, and also careful pre-op evaluation of whether the pedicles are intact or not. Still, significant lacunae in literature are present, and they require more multicentric trials with a larger follow-up to shed more light on this topic. These were my references. Thank you.
Thank you very much. Paper is now open for questions. Over to judges.
Yeah, it was a very nice presentation. To be honest with you, you have covered most of the meta-analysis. You have properly analyzed those. You have mentioned what are meta-analysis and the number of patients involved. So it was a good presentation. However, I have a question. In terms of if you do a short segment or a long segment fixation in a young patient, do you think can we remove those implants once the fracture has been fixed?
Yes, sir, definitely we can remove the implant.
United.
Yes. Yes, sir. Once the fracture is united, it is possible to remove the implants. However, the implant removal process is also associated with its own morbidities. In our context, lot of patients may not agree to it. However, it is definitely possible to do that. But it has also been found out that if the implant removal is done after a significantly long amount of time, then that may be involved with the facet joints already being damaged or being fused as a result of the long period of immobilization. So that is also a concern.
Okay, so did you find in literature what is the ideal time to remove that once it has been united?
No, sir, I did not read.
Fair. Okay.
That's a great presentation, I would say. So your take-home message is what? Long segment or short segment?
Sir, it has to be individualized based on the patient that you are dealing with and the kind of fracture that the patient has. If suppose it is a osteoporotic patient, or if there is a unstable fracture, then long segment fixation should be preferred if suppose the functional demands of the patient is not so much. If it is a young patient with higher functional demands, and with a relatively stable fracture pattern, then definitely short segment fixation is to be preferred. If suppose you want to do short segment fixation in a patient where you are afraid that there may be some implant failure, then you have to augment it with whatever techniques I have told. You have to carefully see the pre-op CT and then decide if the pedicles are
Okay,
intact, if
Aditya,
it is
I got your
possible to.
point. Thank you very
Yes.
much. You indeed have researched this well. I'm not going to go ahead with the next question because you answered that in your first. Thank you. Good presentation.
Dr. Ashok Sham just wanted to confirm, has he completed in time?
Yeah, it's completed. Yeah.
Yeah, perfect. Thank you.
Dr. Bhavin, you have any questions?
Yes, I definitely have. Yes, so Aditya, yes, it was a very well structured and the content was good, excellent research and everything. So, what are the reasons of failures that did you find in your studies in short or in the long segment fixation? So,
Sir,
because
what I found was that there are three primary ways in which the implant fails. Either the screw breaks or it bends, or there is loss of the kyphosis correction that has occurred. So there is translation of the vertebra anteriorly, and thirdly there is back out of the distalmost screw that occurs. So there may be different causes for it. Either the bone quality may not be good, or if there
so
is a void in the anterior column, then there may be progressive kyphosis over time. Or if the screw technique of placement of the screws is not well, the screw does not have good purchase, then that might lead to failure. These are some of the causes.
Aditya, the single most important cause of failure is the anterior column, which is not reconstructed or you
Yes.
fail to identify to support or fuse it. The technique of fuse, it may be long, short, doesn't matter much. So, but if your fundamentals are clear and if you have judged the where the short segment would work or the long segment would work. So I would say along with the posterior ligament composites, the anterior, so that's where the CT scan and the communication is important. So you can put a bone graft in. So where you are able not to assess those anterior and not address that anterior column, that's where it goes into kyphosis. That's what.
Okay.
Any more questions? That's a
Yeah, excellent presentation, Aditya. But I just wanted to know, in your literature survey, could you find, since you said there are indications are to be created for short segment, that the patient has to be chosen, could you find any gray areas that those fractures maybe end up in conservative side, or maybe MIS short segment would be as good? Did you do any literature search in relation to this? That would we
Sir, I
tend
tried.
to, like we are trying to reduce the indications for short segment, then is there any gray zone with the conservative treatment in those areas? So like everything
Sir,
where a PLC is involved, you will do a two level about two level. But short segment, you will do intact PL, intact posterior longitudinal ligament. Then would that be an overlap for conservative treatment? I'm just asking if you could find any literature. I don't want your experience on that.
Sir, in terms of literature, there have been lot of classification systems that have been described to decide
Mm.
if the surgical treatment has to be done or not. So, for example, where TLIF score is 4, then that is a sort of situation where you can do short segment fixation or you can do conservative treatment based on
So
your
was there any
experience.
study where they compared that? No, you couldn't get it.
No, sir, I did not
Okay. And
come
second,
up.
like in MIS, since you have preserved soft tissues, and this does that make any difference? Make it short segment a little better as
Sir, I
compared
tried to
to
find a lot of literature on whether MIS technique has a difference, but I could not
yeah.
find any literature.
Okay.
Yes,
Okay, no problem. Excellent presentation.
okay.
thank you, sir.
Thanks, Aditya. We'll like to invite the next presenter, Dr. Taarini. Please share your presentation and we can start.
Yes, sir. Oops, just a second.
Okay, go to slideshow and we can see your presentation.
Yeah. Okay.
Yeah, go ahead. It's full screen now.
Okay. So good evening, judges, colleagues, and viewers. So my topic for today is indications, outcomes, and complications of transforaminal endoscopic discectomy. I've used peer-reviewed articles from 2018 to 2023. So this procedure has been around and developing since quite some time. Dr. Parviz Camben described the transforaminal access in 1970s. So what is it? I mean, it's a keyhole procedure in which we perform a discectomy by passing an endoscope through the Camben's triangle. But what was the need of doing this procedure in the first place? It was to devise a safe way to reach the disc herniation that doesn't require much bone removal or muscle retraction, hence the bypass surgery. So the goal of this literature review is to determine the ideal patients for the surgery, evaluate the outcomes and the complications. Going briefly over the steps, I will only highlight the differences to the conventional discectomy surgeries. So these patients are usually positioned prone or lateral, and most of the surgeries are done under local anesthesia, but general anesthesia can also be done. The entry point and the incision is around 8 to 12 centimeters lateral to the midline, depending on the level of the surgery. Then the working corridor is between the exiting nerve root, the superior end plate, and the superior articular process of the desired level and the side. Some surgeons prefer to resect the extra-articular part of the superior articular process as well to make more space and to dock the scope better. Instruments are then passed through the endoscope after docking to perform the discectomy as seen in the video. So, what are the key indications? Well, all studies have suggested that classical indication is an ipsilateral soft disc herniation, which may be foraminal, extraforaminal, or the common posterolateral. But with recent advancements and increasing experience, the indications now can be expanded to migrated, recurrent, partially calcified, and central disc herniations. So there are contraindications, but multiple methods now have been devised to overcome most of these. For example, the use of navigable instruments have made the complete removal of a very high grade migrated disc effective. However, the procedure is technically demanding and carries a risk of epidural bleeding. So the second example here is a patient who has an L5-S1 lumbar disc herniation and also has a high iliac crest. Some surgeons prefer to do a trans-iliac approach. I didn't come across many studies that have large sample size, but multiple small studies of 10 to 15 patients have suggested that it is a safe and an effective technique. These are some more such examples that have been modified with a modified technique. We can use the transforaminal approach. For example, during spondylar discitis, we can go for biopsies. In obesity, we use longer scopes and take a more lateral entry and more. So for outcomes, I have chosen this 2-year prospective study as it is a multicentric study with a large sample size. It has 10 Indian centers. And so 591 patients underwent discectomy between the years of 2017 to 2019. I am restricting my comparison to transforaminal endoscopic discectomy, microdiscectomy, and tubular microdiscectomy for this presentation. So as you can see that the functional outcomes are comparable between all three procedures. So were the mean operative time and the average hospital stay. But the significant differences do lie in the incision size and the mean blood loss. However, looking at the bigger picture, these comparisons are being made between all procedures that are hardly going to have more than 100 ml of blood loss or the maximum incision sizes of 60 mm. But does size matter? So you could say that a small 7 mm endoscope uses an incision of what? 8 mm, and where the typical tube size used for an MIS surgery is 16 mm. Coming to complications, these are the highlighted complications in most of the studies that says that are recurrence, reoperation, dural tear, and dysesthesia. Although recent studies have shown that there is no statistically significant difference from other conventional techniques. But there are two notable points. That is the high cost of instruments and the radiation exposure, which is more during a surgeon's early experience. So this is an interesting paper where 3 surgeons were trained for the procedure of transforaminal endoscopic discectomy by a senior surgeon. After performing up to 20 cases under supervision, they started operating on their own. Now, the results of those early surgeries were compared with the later surgeries. So 613 patients here were randomized into two groups, the microdiscectomy group and the transforaminal endoscopic group. The further divisions here show that the endoscopic group patients were higher for the senior surgeon and have a decreasing trend for the other surgeons. So the study showed that the newer surgeons, they took more surgical time. So the senior surgeon took around 30 minutes to do the procedure, whereas the newer ones were around 1 hour. And the recurrent rates were higher for the newer surgeons as well, with around 15 recurrences. So the patient reported outcomes were comparable between the early cases and the microdiscectomy group, which I think is interesting. But when the microdiscectomy group was compared to the later cases show statistical significant more favorable outcomes in terms of leg pain reduction. So what are the limitations of the technique? It's a steep learning curve, not ideal for all types of PIVD, especially for beginners, and the cost of instruments. But my take-home message here would be, it is a good technique for ipsilateral soft disc herniation that are either foraminal or extraforaminal. Outcomes are not statistically different from other conventional discectomy techniques. Patient selection is the utmost importance, especially when we are just beginning to do this procedure. There is a steep learning curve, recurrence is high, and especially in the early times of this surgery. But the benefit of this surgery is it can be done under local anesthesia, allows for direct access and visualization of pathology, enclosed environment, and the resection of the superior articular process is very less compared to other procedures. Thank you. These are my references.
Thank you, Taarini. She finished well in time. Over to judges for their questions.
Yeah, Dr. Taarini was a nice presentation. I have two questions in terms of how many cases have you come across your research that they have done under local anesthesia, and how many cases have they done under general anesthesia, and were there comparable results or were there any problems intraoperatively in terms of pain?
So the most preferred and the selection is also based on these things that the patient would require local anesthesia. So in the papers that I've read, most of the surgeries were done under local anesthesia. But even and sometimes they also give sedations in patients who had anxiety. But patients who did want to undergo a minimal access surgery and did not want to be awake throughout, they were given general anesthesia, which would be less than 20%. But they also had comparable outcomes. There was no significant difference.
Okay. And in terms of the recurrent disc herniation, the chances of the patient undergoing surgery after a transforaminal endoscopic surgery rather than a microdiscectomy or a micro laminotomy, are they different? Did you find out anything in terms of that?
So the study that I talked about, the one with the young surgeons, there was a microdiscectomy group comparison as well, where I saw that although in the microdiscectomy, the recurrent surgery rates were very less compared to the endoscopic for a newer surgeon, but for the similar higher number that was above 150 for the senior surgeon, they were less compared to the microdisc.
Thank you. Thanks a lot.
Thank you, sir.
Dr. Vishal.
So, great presentation. Just one question. What was the return to surgery rate due to complications in transforaminal? Did you come across any articles vis-a-vis a microdiscectomy or a tubular?
So the one where I stated complications, it was said that there is a 6.9% rate of recurrent surgery, and this was done in that prospective study of 2 years with 519 patients. They had undergone microdiscectomy through all the procedures, including all the conventional discectomies, including open, as well as the endoscopic. So the recurrence was a little higher in the endoscopic group, but not very less. I mean, there was
what was the recurrence rate and what was the return to OT rate for surgery? Is there a clarification as to did all recurrence need surgery, or there was recurrence but could be managed conservatively?
So there are two. Recurrent surgery was 6.9 and recurrent disc was also 6.9 in that paper that I quoted. I have not seen specifically that the ones who had a recurrent disc, did they have to undergo a surgery, or what was the management for those patients?
So this recurrence rate was there a specific sub-classification as to what group herniated more compared to the others? As in not the technique wise, but what kind of disc herniation herniated more? Age group and the
When I was, thank you, sir. When I was researching for high grade migrated discs, it was said that the inferiorly migrated discs had a higher rate of recurrence, but I did not look into any bigger sample size that would say this specifically.
Okay, thank you. Thank you very much.
Thank you, sir.
Yeah, Dr. Bhavin.
Yeah. A good presentation, Taarini. So
Thank you.
only reason, was there recurrence or a residual disc? Did you find any correlates with that? Because if you're talking about inferior migrated disc, sometimes the entirety of the disc herniation is not removed. And that's why you feel there is a recurrence rather than some residual disc left behind. So I would want an answer regarding, have you seen the
Yes, sir.
recurrences
Yes, sir.
were purely recurrences or they're residual disc?
So most surgeries now, they do this ablation of the annulus after the discectomy. So the recurrences in the papers were higher due to migrated discs. And so that was the what was the papers were suggesting of.
No, I think you didn't understand.
Sorry, sir.
Was
The residual disc.
residual or was it a recurrence? So how can you
Maximum were
differentiate?
residual, sir.
Exactly. So it was not recurrence, it was actually residual disc left behind, which was the cause of.
True, sir. Yes, sir.
Thank you.
Sir, any questions?
Taarini, did you find anything regarding the versatility of the procedure? Like in micro discectomy, we can do 2 levels, we can do same simultaneous. Was there any recurrence rate regarding that? So, or you just looked at the one single level in all these comparisons?
So I have seen in this one thing I was looking at, that it is said that ipsilateral discs do better. So I wanted to know, if somebody had a bilateral symptom, what is to be done? So this is where I found that the procedure was versatile, where the transforaminal endoscopic discectomy could be carried out from that affected side. And once that was done, surgeons usually seal that side and then do the same procedure from the other side. So bilaterally, it could be accessed. Again, it required technical skills and higher experience. And the others where versatility comes in, there were like a lot, like I said, a lot of modifications to do certain things that were previously thought were contraindicated or not possible through endoscopy.
Okay.
Like trans-iliac
Thank you.
approaches and thanks.
Right.
Good
Thank you,
presentation.
Taarini.
Thank you.
Thank you, sir.
I'll invite my next speaker, Dr. Abhijeet. Abhijeet, please share your presentation. Okay, we can see it. Make it full screen and start. Hello, you can start the slideshow. Is
Yes.
there any problem, Abhijeet?
The audio is not started.
Audio is started. We can hear you. Go ahead.
Good evening, everyone. This is Dr. Abhijeet. Greetings to the respected judges. It's an absolute pleasure to present in front of the dignitaries at BOS Rising Star 2024. The topic for my presentation is lumbar spine fusion, MIS TLIF, indication and short-term outcomes. As we all know, lumbar fusion is the ultimate solution for most of these spinal pathologies, with open surgery being the foundation stone. However, with improvement in the minimal access techniques and in the era of minimal access surgery, it is very important to upgrade ourselves. And to substantiate that upgrade and shift towards MIS, we need to have robust literature evidence. So the objective of my presentation today is to review the literature and to come to a conclusion regarding this aspect, that is the short-term outcome and the indication. Coming to the indications, anything and everything what a open surgery can offer, MIS can also offer that. So the most important and commonly seen indications include stenosis with DDD, isolated degenerative disc disease, large central HNP, large facet cyst, listhesis, either degenerative or lytic, degenerative scoliosis, recurrent HMP, infections, and apart from this, we have failed back syndromes, etc. What makes MIS specific is I want to share that with the help of this image. Look at this lady, what not she has. Dyslipidemia, hypertension, IHD, uncontrolled diabetes, recurrent UTI, on top of that, large disc with a foot drop. If anyone want to do a open surgery in this patient and dig a well to find water, then it's their choice. So these are the other specific conditions where MIS would prove more beneficial than the open. So this is a study which was done by Bhau Garg, and the indications they told in their study were also similar, that all the indications for open surgery stand good for MIS as well. Coming to the short-term outcomes, the second part of the presentation, we all know that all the spinal fusion techniques ultimately on long term gives us the similar results. But the one who stands tall is the one who gives most beneficial result in very short term. So I want to quote this study Sebastian published in 2022, where they did a prospective study involving 38 patients in open and 23 patients in MIS category. And they followed up the patients on first day of the surgery, third day, sixth day, and subsequently on second week, fourth week, and 12th week. What they found was score, the quality of life, the visual analog score, all those were significantly improved when compared to that of the open technique. And at 3-month follow-up, they came to the conclusion that MIS gives better results. And on top of that, the minimal scar, minimal post-operative pain were cherry on the top. Another study I want to quote here is the comparison done for clinical and radiological outcomes, open versus MIS TLIF technique, wherein one it is a retrospective study where the follow-up was done at 1 month, 3 months, 6 month, and 12 month, with VAS and ODI as the clinical outcomes, and lumbar lordosis, focal lordosis, and pelvic incidence being the radiological parameters. And they concluded this study with the conclusion that MIS TLIF is associated with less intraoperative blood loss and hospital stay. However, the operation time was more, but these results were at the end of the 12 month. When we consider the furthermore shorter time span, that is 1 month, 3 month, and 6 month, MIS gave better results when compared to that of the open TLIF. Here is another study comparing open versus MIS technique. And the conclusion here they said was fusion rate and complication rate for both the open and MIS techniques were similar, and the readmission rate or the revision surgery was more in case of MIS TLIF. But at last they also attributed to the fact that maybe the training and the experience was a factor for the readmission or the revision rate. Another wonderful study where they did a narrative review comparing minimally invasive versus an open TLIF procedure, and and the conclusion of the study was the potential benefits of MIS TLIF might be present in the early recovery period after the surgery, but the long-term outcomes are same for both the MIS as well as open TLIF. The overview of this narrative review can be tabulated in this form, where the operative time was shorter by 40 to 70 minutes in around 6 to 16 studies, while it was longer by 10 to 90 minutes in around 5 studies, while intraoperative bleed was reduced by 100 to 500 ml, and there was no difference in about 6 studies. Ambulation time, opioid use, return to work, ODI, VAS, complication, revision surgery, cage migration, and readmission or were less in case of MIS TLIF when compared with that of the open technique. So when we tell that MIS is better than that of the open technique, that means we have something to compare. So Amitabh Bachchan is Amitabh Bachchan on a lighter note because we have the comparison as others. But when we compare to someone who is of the equal capacity, then the options and the discussion can be there. And when there is a fight between the two things, if we get another one, then there might be another opinions, and that could be a point of discussion. And certainly the most delicate one at the last. So I have compiled few studies where the MIS TLIF is compared with another kind of fusion techniques. That is, first thing is the endo TLIF versus the MIS TLIF. In this study, the results shown that endo TLIF group has similar return to work time and the rate. However, the other parameters like blood loss, bedtime, analgesics ratio were significantly less in endo TLIF group. But at the 3-month follow-up, the endo-TLIF group had lower back pain than compared to the MIS. But the fusion rate in both the groups were similar. Similarly, we have another study comparing endo-TLIF with MIS-TLIF in a single level lumbar degenerative disease. The table which is present downward, it shows that apart from the operating time, which was more in the endo-TLIF group, MIS, which was more in the endo-TLIF group, all other parameters are superior to that of MIS-TLIF group. But the exposure of the radiation was higher in endo-TLIF group. So the conclusion here was to weigh against the operation time and the morbidity of the patient as well as the exposure which a surgeon wants to take, and dependingly the results were and accordingly the results were comparable. Another is a good study where the MIS TLIF was compared with OLIF, and they found no significant differences regarding the back pain relief, functional recovery, complication, disc angle restoration, lumbar lordosis, or fusion rate. So we have done the endo TLIF as well as the OLIF, and this is one more study where three-way comparison was done and matching was done between the MIS TLIF, XLIF, and the OLIF. So multiple comparisons were done with these three groups in terms of operative time, blood loss, complication, DVT, thigh pain, and most of the time the MIS gave the good results when compared with the other techniques. So as a whole, we can tell that XLIF, OLIF, MIS all are safe. Clinically, the XLIF and OLIF both they give equivalent results to MIS TLIF. They achieve the indirect decompression while MIS TLIF give you the direct decompression. And these can be taken as a good alternative to MIS TLIF until proved otherwise. So the conclusion would be indications for MIS TLIF are similar to that of open. MIS TLIF is obviously superior to open surgery when other parameters like comorbidities are taken into consideration. MIS TLIF give excellent short-term outcomes. MIS TLIF has comparable results to other fusion techniques. These are my references.
Thank you, Abhijeet.
Thank you.
Finished just in time. Over to judges for the questions. Abhin, unmute yourself.
Abhijeet, a nice presentation, but I have a few questions. Like, in terms of MIS TLIF, you have not emphasized enough in terms of, so the most important thing what we compare between MIS TLIF and open TLIF is in terms of the radiation exposure. Okay, you have not emphasized enough in terms of how much radiation. You have just shown one study in terms of that, but you have not emphasized enough in terms of that. The second thing what I would mention is in terms of time. What was the time, or was it comparable in your studies, MIS TLIF and open TLIF?
Yes, first of all, regarding the radiation, the studies showed that as less as 8 to 10 shoots were taken in the open surgery, while compared to that of MIS, around 60 shoots were taken. So it is validated in around 4 to 5 studies which I've come across. So obviously, MIS carries the risk of more exposure to the radiation when compared to the open surgery. This is the one aspect, sir. This, sorry, I missed
The
the
second
second
aspect
question.
in time, in terms of surgical time.
Yes, sir. The surgical time, as also in around 7 studies, it was reported in MIS, the time reduction is by around 10 to 60 minutes. But when you compare that with the open surgery, the time frame will get increased by around 90 minutes, up till 90 minutes. So,
Okay. And the other thing what I want to ask is, did you find any studies which would help to mitigate or decrease the radiation risk, like navigation or any other techniques which would decrease the radiation risk for MIS TLIF?
yes, sir. The use of navigation, obviously, it reduced in studies which I've come across. They stated that it reduced the
Which
exposure.
studies? Which studies? Did you find out any studies? Did you see any studies?
Yes, a couple of studies I have seen, sir, where they compared the MIS technique with fluoroscopy guided versus navigation guided. In
And what
those
was the
studies,
result?
so the exposure was obviously less in the navigation guided, but the time taken for the surgery, the operative time and all were more in the navigated surgeries.
Okay, thank you. Thank you.
Abhijeet, can you elaborate on the studies for navigation that you have seen, which have not come on this presentation? And other thing is, in the short-term comparisons, you have also added XLIF and OLIF to that. Is there a comparison of short-term complications on all the procedures? Open versus MIS versus OLIF, XLIF, and the EndoLIF?
So the complications were more present in the XLIF and the OLIF when compared to the MIS in terms of the thigh pain, the reduction in the power of the flexion of the hip. In few studies I've come across, maybe because of the involvement of the more stretching of the nerve, or the neural iatrogenic neural damage can be the reason. And about the navigation, I'm not able to recall the studies names. But
Coming to the other part, in severe lumbar canal stenosis, which you will agree is an open as well as an MIS TLIF indication, are OLIFs and XLIFs also an indication for that?
yes, sir.
In
They
severe,
in severe stenosis, I've not seen much of the OLIF and the XLIF parts, sir, but still the basic thing with the basic knowledge what I have in
no,
severe
what have you
stenosis,
read
I
in
think
the literature for it? What was the review of the literature that you found?
for severe yes, for severe stenosis, MIS TLIF would be better option, sir, because there is a hypertrophy of the ligamentum flavum and there is more compression from within the canal as well. When you do the OLIF for the XLIF, it is just the restoration of the height and indirectly decompressing the canal. I would tell MIS TLIF would be better than the OLIF for the XLIF.
Which of these procedures is superior in sagittal balance restoration in the short term?
Both are equivalent.
Which one? Open, MIS, OLIF, XLIF, or EndoLIF? You have
So the
compared
MI. So I've come across studies with open as well as open and the MIS both have equal sagittal balance.
OLIF and XLIF, have you compared them?
No, sir.
Okay, thank you. Thank you, Abhijeet.
Dr. Bhavin?
Yeah, Abhijeet. So looks like you're sold out to MI still, huh? Like you're saying it is very better than the rest of the other TLIF procedures. So, but you also mentioned regarding the recurrence rates, if I'm not mistaken, or revision rates in MIS TLIF. Any reason for that you have mentioned?
So in that study particularly, they said that the revision or the readmission rate could be because of the less training on the part of the surgeon. They were not that experienced. Maybe the learning curve is steeper. That would be the reason for the recurrence or the readmission rate.
Then what were the reasons for the revision? So what
So
was
the reasons?
reasons? Was it non-union? Was it screw misplacement or any other reasons for the revision rates? So what was the reason for the revision? in the short term or in the mid term or in the long term? Any studies you come across regarding that?
Yes, sir. I've come across the studies, sir, where in MIS as well as the open, the malpositioning of the screw was more seen in the open group than the MIS group because of the guidance under which it was done, fluoroscopy guidance, one thing. And the second thing was the complications related to the dural puncture was seen in two studies, sir.
Okay, thank you. Thank you.
Yeah, and Kate subsidence is also one that I've seen with the TLIF, MIS TLIF.
MIS, so what is the reason? Any reason? Gate subsidence, why was there the increased gate subsidence in MIS TLIF?
I'm not able to recall it.
So, okay. And what was the short-term, what you consider by short-term outcomes? How much period have you
So
considered as short-term?
Here in my review, I've considered it till 6 months, sir. Only one study where I've taken it was until 12 months. And the results in that study at 12-month follow-up was similar to other, but at 6 months and 3 months follow-up, it was far more superior than to open surgery.
And what is the take-home message from your side in terms of MIS TLIF or open TLIF?
So, if we compare to the open technique, MIS technique is superior or far better, I would say. And when you compare MIS with the other fusion techniques, then it is the surgeon's choice and the expertise with which he does it, because there is no much significant outcomes in terms of shorter outcome when we compare with the other techniques. So the future proposition for the research and all should be directed towards that, as well as the surgeon should get trained in whatever the minimal access technique he wants to do it. But one need not to forget about the open surgery. One has to be have adequate exposure of.
Okay, I think we need to move on.
Thank you.
There, sir, if you have any.
No, I can go ahead. No questions.
Okay. Okay, let's move on to our next candidate, Dr. Ragha. Please go ahead and share your presentation.
Yes, sir.
Thank you, Dr. Abhijeet. That was good.
Thank you, sir.
Okay, we can see your presentation. You can start. Make it full slideshow.
Yes, sir. I have, sir.
Go ahead then.
Good evening, everyone. The panelists, my colleagues, and the seniors. Greetings. Today, my topic is cervical laminoplasty, the outcomes and complications of double door versus single door laminoplasty for cervical myelopathy. So it was first introduced in 1973 by Hattori et al. It was a surgical treatment for spondylotic myelopathy and ossification of the posterior longitudinal ligament. And this was different because it was preserving the posterior elements and therefore eliminating the need for fusion. It's a motion sparing procedure that allows for earlier and more aggressive rehabilitation. It also avoids complications like instability, sagittal malalignment, perineural scarring, and which are often associated with laminectomy. So next three slides is going to be from a review of literature from the Neurosurgery Clinics of North America Journal. The types of laminoplasty, there are three types. One is a Z-shaped laminoplasty. This is the Hattori's original description, where the lamina are attenuated with the drill and Z-shaped laminotomy are performed. And then the split lamina are elevated and sutured to construct the expanded spinal canal. Now, this is the other next development, which was described by Hirabayashi in 1978, where this is the open door, where bony gutters are drilled bilaterally at the lateral margins of the lamina, and the bone is completely removed on one side while preserving the inner cortex as the hinges on the other side. The spinal canal is enlarged by opening the posterior bony elements, and the lamina are kept open with sutures on the facet capsule on the hinge side. There are many variations of this type where people use tension band wiring. People sometimes use a plate, a specific plate that comes. And now, this is the double door laminoplasty, or also known as the French door laminoplasty, which was described by Kurokawa in 1983. where a midline laminotomy is done by splitting the spinous process, and later lateral margins of the lamina are drilled to form hinge gutters. The lamina are then elevated bilaterally to achieve enlargement of the spinal canal. Artificial spaces such as hydroxyapatite are used to keep the lamina open and sutured. Now, what are the indications? The indications, as we know, is for cervical spondylotic myelopathy due to disc integrity loss, facet joint or uncovertebral joint hypertrophy, congenital narrow canal, traumatic central cord syndrome, or the OPLL, the ossification of the posterior longitudinal ligament. So how do we assess the myelopathy? So one of the most commonly used score is the Japanese Orthopaedic Association score for cervical myelopathy, where they assess the motor function of the upper extremity, lower extremity, bladder function, and sensory. And where there's a total score of 17. And from this article from the spine, Vada et al. Have described a surgical treatment is necessary in patients with a JOA score less than 13. So let me introduce you to K-line. So K-line has been developed. It was a groundbreaking paper where K-line has been described by Fujiyashi et al., where a central line is drawn from the midpoint of the canal from the C2 to C7, and then it is compared on the lateral X-ray where the OPLL is crossing the K line or it's not crossing the K line. So if it is on the ventral side, then it is a positive K line, and if it is touching, then it is a negative K line. K in K line stands for kyphosis. So this is a determinant which we are going to use whether to go for a laminoplasty or not. So cervical kyphosis again is a relative contraindication for any laminoplasty. So a negative K line or a cervical kyphosis more than 13 degrees is a relative contraindication for laminoplasty, which has been described by this journal from American Academy of Orthopaedic Surgeons in 2018. So in this radiographs, if you see the left first one, it is a positive K line. And here, the right side too, again, if you see, they are negative K lines, where laminoplasty is contraindicated because there is no space for the cord. Now, this is a study where from the Spine Journal, where they have compared the effectiveness of open door and versus the French door, where 92 patients were randomly grouped into either the open door or the French door. And several parameters have been assessed. So most of the other parameters like the operative time, the blood loss, the duration of hospital stay, most of them have been equal. Where the difference came in was when they calculated the angles, the range of movements, and etc. For example, in open door, there was more reduced cervical angle, and post-operative range of movements were better in the double door, and post-operative extension angle was better again in double door, and range of movement reduction was more in open door. So there was a mean reduction in the cervical lordotic angle in the open door. So this study showed that the double door was superior than the single door. Now, again, this is one study where it's a meta-analysis where 6 studies, which included 430 patients, were assessed, and they were assessed for the JOA scores. And what they understood was that the canal expansion was significantly higher in the open door laminoplasty compared to the French door laminoplasty. Other than the canal size increase, they did not find any other significant differences, like the blood loss complication rate, the C5 palsy rate, the axial neck pain, or the range of movements. Now, this is one more journal from the European Spine Journal, where they assessed 33 patients who underwent open door and 20 patients who underwent double door. So in this particular study, they calculated the spinal width of the spinal canal and the inclination angle of the lamina at C5 and C6 levels. So at C5 level, they did not find much difference. although at C6 level, the open door laminoplasty, there was much more increment in C6 level in open door method compared to the double door, whereas the inclination angle of the lamina was significantly higher in the double door. Now, consideration, the same journal, they also recommended a few considerations when you're confused which laminoplasty to go with. The open door laminoplasty, if there is a myelopathy combined with only unilateral radiculopathy, or if there's a large prominence of the OPLL, or if the patient has tiny spinous processes who cannot undergo a double door. While coming to the double door laminoplasty, your regular myelopathy cases, small and slightly prominence of the OPLL and myelopathy combined with bilateral radiculopathy, and also the stenosis, if it is combined with any instability where posterior instrumentation might be required, for example, like rheumatoid arthritis and etc., then a double door is preferred because the expansion of the bony canal is more symmetrical compared to the open door. So coming to the complications, one of the common complications we need to talk about is the C5 palsy. This is one of the article from the JBJS where 1858 patients have been assessed, and out of them only 2.3% of them have developed a C5 palsy. But the C5 palsy was not associated with which type of laminoplasty, whether is it open door or a double door. One more complication is the axial neck pain. This article from the Spine, where they assessed 91 patients who underwent single door and double door. This one is from the single door laminoplasty, where C3 to C7 and C3 to C6 laminoplasty were compared. So significant axial neck pain was rarer after C3 to C6 procedure compared to C3 to C7 procedure. So C7, basically what they understood is that C7 should not be included in the cervical laminoplasty because the C7 spinous process is connected to the scapula by trapezius and rhomboidus minor muscles and has been critically important in the biomechanical functions.
Dr. Ragha, I mean, you have extended almost more than a minute of your time.
Yes, sir.
If you can conclude right away.
Yes, sir. So the take-home message is patient selection is the key. Laminoplasty is a better alternative to laminectomy or laminectomy with fusion. There are no clear advantages of one technique over the other, whether single door or double door, and preservation of the semispinalis muscle is the key for a favorable outcome.
Right. Dr. Ponnam, nice presentation. You extended your time by about a minute. That's a problem. But anyways, do you have any meta-analysis comparing laminoplasty with laminectomy?
Yes, sir. But there are studies that I've come across. But the problem is, depending upon the level that you choose, the outcomes are quite varied, sir. So if it is a and the technique that you're followed. In laminectomy, if you're performing C2 dome osteotomy without disrupting the spinous process, then the post-op pain or the range of movements are much better in laminectomy compared to the laminoplasty. The main problem with laminoplasty has always been the range of movements.
Okay, and in terms of, I just had one more question, sorry. In terms of the long-term results about the motion preservation, do you think are there any significant differences between laminectomy and laminoplasty?
Sir, when it comes to preserving the range of movements in long-term, laminectomy is any day better over laminoplasty, sir. Because laminoplasty is good, but it also comes at a certain cost, and the patient selection is very niche over here, sir. Very limited is what I felt.
So do you have any hard numbers in terms of what was a preserved motion?
Yes, sir. So one of the main problems, we are doing laminoplasty to preserve the motion and all, but the problem is that the interspinous ossifications and also unwanted fusion happens in laminoplasty in long run. So in long run, there is not much difference.
Okay, thank you. Thanks.
So, Dr. Ragha, the question is what is the complication rate and need of revision in these two procedures, between the two procedures?
Sir, I personally have not come across any study that particularly pointed out differences in the reoperation rate between the open door and the double door, sir. But mostly they have been combined studies together as a laminoplasty. I've tried, but there were no studies that were done separately in a long-term outcome reoperation rates.
What were the average revision rates for any of the laminoplasty procedures?
Sir, the revision rate was in fact slightly higher when it came to single door compared to double door, sir. And the resurgery rate was about 5 to 6% in this one particular study I have come across in Global Spine Journal at a 10-year follow-up.
And the cost analysis on the use of implants for doing any of these procedures, is there a difference?
No, sir, because open door procedure can either be done with, you can either use sutures or you can use a tension band wiring, or the cost goes up only if you use a plate. Now, that's a surgeon's preference, sir. So it can get expensive if you use a plate. It can also be done in an economical way if you use sutures or if you go ahead with the tension band.
What is the loss of the correction that you get post laminoplasty when you do not use implant versus when you use suture?
I'm so sorry, sir.
What is the chances of the door falling down when you don't use an implant and use a suture instead?
Sir, it depends on how many levels you're planning on doing the laminoplasty, sir. If it is a long laminoplasty where you're including from C2 to C6, then it's better to go for an implant because it's risky to go with the sutures. Only if you're doing a short segment laminoplasty, then you can afford to go with
Can you define a short segment laminoplasty?
Sir, where you can go with from C3 to C6 instead of including C2 and C7.
Okay, thank you.
Yes.
Dr. Bhavin, any questions?
No questions, sir. I think most of the thing has been covered.
There, sir, any questions for him?
No, we can go ahead. Yeah.
Okay. Thank you, Dr. Ragha. Let's move on to our next candidate, Dr. Gaurav. Gaurav, you can share your presentation and start.
Good evening, everyone. It's a pleasure to present in front of such a esteemed panel. Today, we will delve into the techniques and
we are
critical
not seeing your
aspects of-
slides. You have to share your slides.
Yeah.
You haven't yet.
Is it visible, sir?
Yes. Make it full screen. Yeah. Now you can go ahead.
So today, we delve into the critical aspect of spinal surgery, comparing unilateral and bilateral laminotomy. We are going to understand not only the technical differences between these two approaches, but also how they impact patient outcome and recovery in quest for effective patient relief from spinal disorder. So my introduction, so minimally invasive spine surgeries, they benefit because of the smaller incision, reduced blood loss, shorter hospital stay, and faster recovery time. These are some of the few of the benefits that we have. The surgical technique, the laminotomy, is a minimally invasive procedure which is designed to relieve spinal canal stenosis by removing the lamina, therefore decompressing the spinal cord. So the comparison between these techniques mainly is based on the surgical approach. the outcome and effectiveness, and patient consideration. Unilateral laminotomy offers a less invasive option with smaller incision, while bilateral laminotomy provides a broader access for extensive decompression, impacting recovery and post-operative pain levels. Both the techniques, they yield similar clinical outcome in terms of relief, and this has been established with multiple research papers which are going to follow. And patient consideration is the very most important factor when considering the surgery, because you cannot get effective relief if the symptoms are there is a severe lumbar canal stenosis with hard disk compressing bilaterally. The choice is dependent on anatomy, symptomatology, and there has to be a balance for decompression with potential risk associated. Unilateral laminotomy benefits are that the technique minimizes tissue disruption. It leads to reduction of post-operative pain and quicker recovery. It is particularly advantageous for patients with localized stenosis, as it effectively decompresses affected areas while preserving spinal stability and reducing the risk of complications associated with more invasive procedures. Bilateral laminotomy, while offering extensive decompression for complex cases, bilateral laminotomy may result in increased surgical trauma and longer recovery times. Broader access can lead to higher blood loss and potential post-operative instability, necessitating careful patient selection and surgical expertise to mitigate these risks. Review of recent clinical trials, they say that comparative effectiveness of technique is very important. Recent clinical trials indicate that both unilateral and bilateral laminotomy techniques for lumbar stenosis provide effective patient relief, symptom relief, with unilateral laminotomy often associated with shorter recovery times and lower complication rates. The complication rates of unilateral are less, recovery time is better, and patient preference is also for unilateral laminotomy due to reduced pain and discomfort is better. So now coming to some of the literature, Lee et al. Says that the conclusion is that unilateral laminotomy led to significant improvement in pain and function with minimal complications. And also we found that it has faster recovery rate, lower complication rates in patient undergoing unilateral laminotomy compared to traditional laminotomy or bilateral laminotomy. Whereas Yang et al., it demonstrated that bilateral laminotomy was effective for patients with bilateral leg pain and provided significant long-term relief. Zhang et al. Reported that bilateral laminotomy improved quality of life and reduced need for revision surgeries in patients with bilateral stenosis. But I was not able to find a meta-analysis which compared unilateral versus bilateral laminotomy, but I could come across a meta-analysis in which there was a comparison of all the surgical techniques. It shows that there is no long-term difference in patients with unilateral laminotomy and bilateral laminotomy if the surgical indications are tailored properly. So this was a landmark paper that I came across, apart from the ones that I mentioned before. This was a midterm outcome after unilateral approach for bilateral decompression. It was a 5-year prospective study. Then also they followed those patients for 11 years, and they found that the complications were less. The revision rates were not statistically different, and the clinical outcomes were better. So the long-term outcomes for laminotomy are evaluated through the metrics such as pain relief, functional improvement, disability reduction. Satisfaction was more, quality of life improvement was better for unilateral laminotomy patients. So they compared 914 patients in group 1, group 2, and this was the conclusion that I just told you was the main highlight for this. I'll skip from the surgical procedure part of it. These are some images which shows that bilateral decompression of lateral recess is very much achievable, and 4, 5, 6 images, they show that the dural sac is adequately decompressed. Key finding in literature. So the prospective Lee et al. And Shi et al. These were level 2 studies in which I was able to see that unilateral symptoms for which unilateral laminotomy was done, significant improvement in pain and functional outcome was seen. And same for the other studies as well. Whereas bilateral laminotomy, it has to be tailored according to the patient based on if we need extensive dissection and adequate decompression. So just to summarize, the comparative analysis of technique, the evaluation of unilateral versus bilateral laminotomy for patients reveals that both techniques provide effective symptom relief, yet unilateral laminotomy is associated with shorter operative time, reduced blood loss, and fewer complications, making it favorable option for patients with localized stenosis, while still achieving comparable long-term outcome in pain reduction and functional improvement. Lastly, we need to understand that we need to select the patient and tailor the procedure as per patient. One shirt cannot fit all. Similarly, we cannot say that unilateral laminotomy is best for every patient of lumbar canal stenosis, and we cannot say that bilateral is required for every single patient. So we have to tailor it accordingly. Patient education important, and post-operative protocols are very important when comparing these results. These are my references. Thank you very much.
Okay. Thank you. Paper is open for questions. Arvind, you can go ahead.
So, Gaurav, fairly good presentation, but I would like to ask you a few questions. In terms of what is your take-home message in terms of, suppose I have a bilateral stenosis, will I be able to do it by a unilateral laminotomy or not?
Yes. Bilateral stenosis can be adequately decompressed via a unilateral approach. And there are many research papers that I've presented that show that you can achieve adequate decompression bilaterally, or both the lateral regions can be decompressed adequately with one approach.
So then what is you emphasize on your patient selection should be very important. What are the criterias then you will go for bilateral foraminotomy compared to unilateral foraminotomy?
So one was a severe compression in which the unilateral laminotomy, we will not be able to decompress the contralateral side, such as hard disc on both sides, and if there is extraforaminal disc on the opposite side. So it will be very difficult, and it has to be based on surgeon's experience, and it has to be tailored according to the MRI findings as well.
Extraforaminal disc on the opposite side. Can you clarify on that?
So, sir, if we are not able to decompress on the opposite side properly with the same uniportal laminotomy, in this we are able to decompress below the spinous process. We are able to decompress the lateral recess. But if there is a hard disc which is present on the opposite side, so it is fairly difficult for without experience to decompress those areas.
Isn't it easier to do the opposite side foramen from the opposite side than from the same side because of the visualization and the angle of visualization?
Yes, sir.
Does your analysis say otherwise?
No, sir. Analysis also says the same thing, sir.
Okay. That's all. Thank you. It is a good analysis.
Thank you, sir.
And Dr. Bhavin, any questions?
No question. Good.
Sir?
Just something like what Arvind already asked, I think. If you're comparing the two, means could you find a simple indication which is like if you're talking about posterolateral disc herniation, unilateral, this laminotomy might be good enough. But as we discussed already, over the top or on the other side, so have you been able to compare or get any literature on this, that when you compare the same thing like in a central canal stenosis, or is there anything which you could get from the literature?
So
Or
for
bilateral
central canal
foraminotomy?
stenosis, they have said that unilateral is very good, and you can achieve adequate
So that's what
decompression with
from the
unilateral.
literature, could you find a clear difference that unilateral, even in such cases, is good?
Yes, sir. Yes, sir. Unilateral is good in such cases as well, sir.
Okay.
Thank you, sir.
Okay. Thank you, Gaurav. We'll move on to
Was he in
last.
time? Was he in time?
Yeah, he was in time. Well within time. We'll move on to our next candidate, Dr. Yash.
Yes, sir.
Please go ahead and share your screen.
Is it visible, sir?
Not yet. It's starting. It is visible now. Go to full screen and start. Okay, you can start.
Yeah, good evening. My topic for today is the role of kyphoplasty in porotic vertebral fractures. I'm Dr. Yash. Porotic vertebral fractures are a very common case scenario which is encountered in daily practice, with about a 20% incidence in the population aged above 50 years of age. Half of them are symptomatic with acute and chronic pain. And the treatment options which we have to offer these people are either a conservative or a surgical management. And both of them are sought with their own set of problems. In an attempt to circumvent the problems of both of these approaches, an intermediate path has come up in the last 25 to 30 years in the form of percutaneous methods. And in this review, I'm going to be attempting to analyze the indications, outcomes, and the safety of this percutaneous method of treating OVCFs. It is a narrative review of PubMed indexed articles of the last 10 years, with the following search commands being used at the time of the review. Ever since it has come in 1998, the procedure, there have been several meta-analyses and randomized trials which have given extremely heterogeneous results. In spite of all this heterogeneity, it is one thing which has been clear is that the conservative management is the way to go for the first line management of acute stable VCFs. Kyphoplasty should only be considered in specific fracture patterns which are stable, or if the time post-injury is lesser than 4 months after the injury and a 3-week trial of conservative management has been given in these patients. It should also be documented on an MRI to be having a T1 hypointense and a STIR hyperintense signal at the body, and the patient should be neurologically normal along with a pain which is functionally limiting the daily activities of the patient. The procedure is contraindicated in someone who has an unstable fracture, or if that patient has recovered significantly on conservative management. Radicular pain forms one of the relative contraindications of the procedure because it may be suggestive of a posterior column involvement, which may increase the risks of a cement leakage. Some technical guidelines are that it is traditionally done through a transpedicular approach with a pressure limitation of 300 psi according to guidelines in the balloon inflation. A maximum of 5 levels can be done simultaneously in a single setting, along with 2.5 hours of procedure duration for the 5 levels. Liquid phase cement injections are best avoided. Coming to the literature review, the most initial articles, the landmark articles published in New England Journal of Medicine in the year 2009, have compared the vertebroplasty to a sham procedure. And the outcome of both of these papers was that there was no beneficial effect of the percutaneous intervention over a sham surgery. Based on these two procedures, the American Academy put out guidelines in the year 2011 and recommended against vertebroplasty in a level quoting the evidence of quoting that evidence, which was level 1 and level 2. The same two authors went ahead to perform a Cochrane review of 21 RCTs in the year 2011, and was the subsequent version was published in 2018. They gave moderate quality evidence against the role of vertebroplasty in routine practice. And they said that the evidence available only stated that there was more potential for harm than benefit as obtained from vertebroplasty. This 2016 article from the Lancet, however, classified the patients and the inclusion criteria as lesser than 6 weeks duration since the pain has begun. And they have concluded that there is a significant benefit of using vertebroplasty in this subset of patients. Another meta-analysis conducted in 2018 has stated that statistical significance was obtained when the efficacy of vertebroplasty was compared against conservative management, and it has stated that the original articles published in 2009, which formed the basis of the AAOS guidelines, they had questionable statistical methods and they did not employ a pre-procedural MRI to identify the bone edema in the vertebra, and hence has refuted their findings. A 2016 JBJS review has stated that percutaneous treatment may be warranted if pain is a relevant problem, and has ruled in the favor of percutaneous treatment in relevant patients, and has stated that it definitely has an advantage when it comes to pain relief. In addition, it has also stated that vertebroplasty and kyphoplasty are equivalent when it comes to functional outcomes and pain relief. Another meta-analysis, the largest of its kind of 34 RCTs, was published last year, and in that they have evaluated 12 different treatment modalities and have suggested that all surgical, including percutaneous techniques, were all superior to conservative management in terms of pain relief. But can this procedure also be used in burst fractures? This study conducted and published this year in the Spine Journal has shown that it is indeed safe to use kyphoplasty in burst fractures of Magel A3 type, wherein the posterior ligamentous complex is intact. They have noted no significant change in the postoperative canal area on the CT scan, and none of the patients also developed neurodeficit. 36% patients did develop cement leaks, but none of the leaks were symptomatic in any of their patients. Cement leaks are a problem in kyphoplasty and vertebroplasty, more so in vertebroplasty, with different papers quoting a variety of incidence rates. Kyphoplasty up to 45% and vertebroplasty going to the tune of 91% in some studies. However, they occur very commonly but are rarely symptomatic, the symptomatic rate occurring in lesser than 1% of all the incidents in most of the reviews. This can also be reduced by using high viscosity cement as compared to low viscosity cement. Another complication is a secondary OVCF, which is used, there at the adjacent level. And in terms of this, they have stated that a vertebroplasty and a kyphoplasty do not have any significant difference, and that a prophylactic adjacent level kyphoplasty does not provide any significant advantage. In terms of decision making, there have been CERSE guidelines published on percutaneous augmentation, and they have stated that though evidence is conflicting, there is a significant benefit of vertebroplasty which outweighs the risk of vertebroplasty of the adjacent level fractures. And there is no strong evidence in support of kyphoplasty over vertebroplasty because equivalent pain relief at a lesser cost and invasiveness has been obtained. Kyphoplasty should only be reserved for indications of local kyphosis greater than 15 degrees in relatively younger individuals and fresh trauma less than 1 week. Pre-procedural MRI is a must. Another classification published in 2018 by a German group has suggested the osteoporotic fracture classification, in which they have stated that OF1, 2, and some cases of OF3 are amenable to conservative or percutaneous methods. And this classification has further been incorporated into a scoring system, which also incorporates some functional criteria such as deformity progression, pain, and severity of osteoporosis. They have stated that this scoring, if more than 6, patients should go ahead for a surgical management, which may be percutaneous or minimally invasive over a conservative trial. The NAS guidelines have suggested that a VAS score of 5 or 8 should be set with respect to the patient being hospitalized or not. A subacute fracture of less than 12 weeks is best done by this method, and a bone marrow edema should be confirmed. A vertebral body height loss of more than 25% or progressive vertebral body height loss is a criterion for kyphoplasty. To conclude, kyphoplasty is more efficacious than conservative management. However, vertebroplasty gives equivalent results at a lesser investment and hence should be preferred. Meticulous patient selection is paramount. Thank you.
Thank you, Yash. Finished in time. Paper open for questions.
Yash, nice presentation. So in terms of, will you do a vertebroplasty or a kyphoplasty in a patient who has got a 15 degree of kyphosis at D12? And based on your research, do you think that it changes the kyphosis angle if you do a kyphoplasty?
Yes, sir. The reviews have suggested that the kyphoplasty is significantly better than vertebroplasty in restoring the kyphosis angle. And that is why a select indication of kyphosis more than 15 degrees, but in a physiologically younger patient in whom height restoration is of more importance than a patient who is physiologically older, who would do better with a less invasive method such as a vertebroplasty. So in that case, even though on paper the restoration of kyphosis is significantly better with kyphoplasty, but functionally they may give the same outcomes if the patient selection is not done according to the guidelines.
And what was the period for which they had examined that kyphosis level? Like, was it for long term or short term? Just because, like, we have a paper, we have done it, and that has shown that even if you do a vertebroplasty or a kyphoplasty, it doesn't change the global alignment. So, do you think that it actually changes the global alignment? Do you think it actually works in terms of kyphoplasty? Why it actually came in was to improve the kyphosis? Does it really work in long term?
Sir, as the review suggested that quantitatively, degree-wise, it may improve the local kyphosis, but that same extent of improvement may not translate into an equal gain of global alignment sagittally, and that functionally the outcomes remain the same. So it is not worth the investment or the invasiveness and the time that kyphoplasty demands over a vertebroplasty, and a vertebroplasty may as well serve the purpose instead of a kyphoplasty, which is almost 4 times as expensive.
Okay, good.
Okay, wait, sorry, Mr. Yash. Yeah, what is the difference between a stentoplasty and a kyphoplasty? The difference in restoration?
Sir, a stentoplasty would be wherein there is a inflatable balloon or an implant, expandable implant, which is inserted, which stays inside, whereas the kyphoplasty balloon is inflated and is taken out.
I'm asking you, what is the difference in the restoration of the kyphosis, restoration of the this vertebral height rather, in vis-a-vis a stentoplasty and a kyphoplasty? Is there a difference? Do you find literature?
Sir, there is a increase, but it is not from the reviews I read, it was not significantly more, but the purpose because of which the stentoplasty had originally come into use, that was the thought process behind it, that if a permanent implant is kept inside, it will lead to better outcomes than a kyphoplasty. But from the reviews I've read, there was no statistical difference between both of them, and functionally also both of them were equal.
Have you heard about a procedure called the spine jack?
I have not, sir.
Okay, it is a very well presented paper. Thank you.
Thank you so much, sir.
Bhavin, any comments?
Yeah. Yash, very well presented paper. All the content was well covered. I had a few questions. Did you evaluate the long-term result of standalone kyphoplasty and vertebroplasty, or in the need of any augmentation with pedicle screws to improve the long-term result? Have you come across any of those papers?
Sir, pedicle screws from there was one paper which has compared 12 interventions which were used, 12 different interventions to treat compression fracture. In that, the best outcomes were in fact obtained with kyphoplasty with additional facet joint injections in terms of pain relief. However, adjacent level fractures were more common in the standalone kyphoplasty group, and because the adjacent vertebrae would have been strengthened by the pedicle screw if they were fixed with the pedicle screw, in that the adjacent level VCFs would have been are seen to be at a lesser incidence. But functionally, standalone kyphoplasty at 1 year follow-up, which is what most of the papers assessed, is able to do better than most of the other interventions which had been tested in that meta-analysis.
Okay.
Thank you. There's any comments?
No, it's okay. Thank you.
Okay, I think with that we come to an end of this session, and I think everybody presented very well this time. Darsa, your closing remarks?
Yeah, I think judges should close. It was all a great session. I think all of the presentations were excellent. Thank you for the judges for being there. Dr. Vishal can wind it up if he wishes to.
It was great to see such great presentations from all of them, and it was all of them have very clear in their thoughts. I think some of them can improve by not being so nervous. I when I started, I think I was more nervous than these guys are. They have a great future ahead. And I'm glad the Bombay Orthopaedic Society is holding such programs which were not there in the past to boost confidence of its young members. Thank you, sir. Thank you for involving me here. Thank you very much.
Thank you very much. Thank you, everyone. Thank you, Bhavin. Thank you, Arvind. And thank you, Ashok.
Thank you, sir.
Thank you, contestants.
Thank you, sir.
Yeah.
So we close this session now.
Bye. Good night.
Good night.
Good night, sir.
Hello. Hello, Ashok sir.